Their counsel, Mr. Walgren, Ms. Brazil. Dr. Kamangar is once again on the witness stand. All jurors and the alternates are present. Everybody, good morning. The jurors, good morning, ladies and gentlemen. And Doctor, good morning, sir. You acknowledge you are still under oath and still sworn to tell the truth. Thank you. This will be cross-examination by the defense. Mr. Flanagan, good morning.
Good morning, Your Honor. Good morning.
Good morning.
Good morning. Dr. Kamangar.
Yes, sir.
Am I pronouncing it right?
That was perfect.
Kamangar.
That's right.
You've reviewed the transcript of Dr. Murray and his statement to the police in this case?
I have.
And you've reviewed the paramedic reports?
That's correct.
Have you also reviewed the medical records of Dr. Kline?
I have.
Okay. In your review of documents, you've become aware of the fact that Dr. Murray did treat Michael Jackson for approximately 2 months for his sleep problems with Propofol, correct?
What I was aware from the records provided for me by Mr. Walgren from Dr. Kline's treatment of Mr. Jackson was...
No, I was talking about Dr. Murray. Did I say Jackson or did I say Kline?
Kline.
Excuse me. Dr. Murray. Dr. Murray treated Mr. Jackson for approximately 2 months with Propofol without problem. Are you aware of that?
I was aware of that, yes.
And you're further aware of the fact that about 3 days before Michael Jackson's death, that Dr. Murray decided to change Michael Jackson's treatment to try and get him less dependent upon Propofol for sleep?
I was definitely the question. I think the question should be that's what Dr. Murray said.
Sustained. We ask.
You are aware of the fact that Dr. Murray stated to the police that he had attempted to change the treatment 3 days before his death to try and get him less dependent upon Propofol.
That's what I read in his interview with Detective Martinez. That's
okay.
Correct.
And you further learned that Dr. Murray stated that Michael Jackson was resistant to this change. Did you see that?
I'm not necessarily sure if I recall that terminology of resistance to the weaning of Propofol.
Well, you recall the Michael Jackson telling Dr. Murray that's the only thing that works for him?
I recall Dr. Murray stating that is what Mr. Jackson was asking for. But as physicians, we are not just there to enable and provide patients with what they ask us for, but to do what's right.
I didn't really ask you about that. I request that last remark be stricken, Your Honor.
The objection is sustained by the defense. Everything after the word but, including the word but in the last answer, is stricken. The first part of the answer remains. Ms. McNeil, can you read back the first part of the answer before the but? How about the question and the answer?
Question. Well, don't you recall that Michael Jackson telling Dr. Murray that's the only thing that works for him? Answer. I recall Dr. Murray stating that is what Mr. Jackson was asking for.
That's the answer, ladies and gentlemen. Everything after that is stricken. Mr. Flanagan.
Doctor, have you, in your practice, ever experienced a patient who was resistant to your recommendations regarding treatment?
Yes.
And what do you do in that type of case?
Well, depends on if it's within the realm of my practice. If I feel like a patient has a problem that is outside of the realm of my practice, i.e. it requires more a multidisciplinary approach, meaning other specialties involved or other specialists outside of my field, I make sure I refer the patient. I think one of the first rules is to realize your limitations. And very often when I have patients like that where they may be difficult and there may be some underlying issues, whether it's underlying psychiatric, psychological, or other medical issues that are outside of my realm, I refer them to those specialists that can help them as well.
Now, if you have a patient that is somewhat resistant to your recommendations in your field of expertise, what do you do in that case?
I need you to rephrase that, because resistance can be if they are just not receptive to the recommendations that I have, or it could be that they're asking for something. So those are two different things. Could you clarify that?
What if they're just resistant to your recommendations? They don't want to do what you think they should do.
Well, patients have a right. Autonomy is very clear. Patients have a right to refuse therapy. As long as they make an informed decision, they have a right to refuse therapy. As much as that therapy I may feel would be in their best interest, they have a right to refuse therapy.
Now, and if they do refuse therapy, what do you do?
First off, I always want to make sure that they are of sound mind and judgment, because that is, especially in the inpatient realm, when their patients have a multitude of problems, you always want to make sure that they are of sound judgment, so they are competent to make that decision. And if that is the case, I really allow autonomy. If patients are aware of the risks, the benefits, and in this case, if they're refusing therapy, what could happen to them if they refuse therapy, that is patient autonomy.
Well, in this case, in your review of the records and review of Dr. Murray's statement of his discussions with Michael Jackson, have you made a determination as to whether or not Michael Jackson was of sound judgment?
Based on the records, I'm not able to make that determination.
In the event that the patient is totally resistant to what you want to do and wants to do it a certain way because he's had success in the past doing it a different way, and it was against your approval, what would you do with that patient?
Objection, the same proper hypothetical.
Overruled. You may answer.
If I feel that therapy is wrong, I refuse. I refuse that care.
Okay. And if the patient was rather insistent, would you continue to refuse?
Absolutely.
Okay.
Again,
would you tell the patient to get another doctor?
I would try to inquire about the reasons why they're refusing. It's very important to try to understand, not just say, well, you're totally making the wrong decision, but really try to get to the root of the problem and say, well, why is it? Why do you have these false misconceptions about this treatment? Do you understand what the risks are? Do you understand what you're doing to yourself? So the first thing I would do is try to get an understanding, as opposed to say, hey, just go to another doctor. I think that's another responsibility of a physician. And certainly by doing that, I can kind of delve deeper and see if that patient perhaps may need another specialist, may need somebody to deal with an element of care that I don't have expertise in dealing with.
Do you know whether or not Dr. Murray had these types of conversations with Mr. Jackson?
Nothing in the records that I've reviewed indicate that.
Okay, and what you've reviewed for the pertinent time is just a statement with the police?
In terms of
Dr. Murray.
Mary's testimony, yes.
Yes, and in the statements to the police, he did describe conversations similar to what you've just outlined, didn't he?
Page reference.
I don't know to what that refers. It seems to me it's vague. Do you understand it?
No.
Sustain.
He did give you a description of, in the statement, he did give a description of of conversations that he had on the night of June 25th with Mr. Jackson and arguing over whether or not he was going to be given propofol, didn't he?
Objection. Can we have a page reference?
I'll sustain the objection. Do you have page line?
No, I don't. I've just...
You may answer it if you're able.
No. I'm not. I don't.
Okay. Would you have, based upon what you have previously testified, in the event a patient just was unwilling to do it in the way that you thought was best, you would tell the patient that you're no longer his doctor?
No, I don't think I would. That's not kind of the approach. Again, I think the approach would be to try to gain an understanding of the reasons why a patient is refusing a certain therapy or asking for a therapy that is totally inappropriate, and trying to understand that to get to the root of it. I think that is still your responsibility as a physician, to try to understand that, to try to seek help for that patient. It's not necessarily as easy as saying, you know what, just go see somebody else. I think I would still try to do my best to try to figure out if they really have an understanding of what it is that they're refusing and what it is that they're asking for that I feel is inappropriate.
In any event the patient just was not willing to do it your way, then you would tell him to go someplace else.
Again, I would want to have a clear understanding. I don't think I would ever use that kind of language to go somewhere else. I think I would try to understand. I would try to explain the situation, try to get an understanding from the patient what the reasons are for making such a decision, and by doing that, be able to get them the appropriate help and say, hey, this is not within, I can't do this for you, but I'm going to get you help because I feel like you may need a certain type of specialist, and this is outside my realm of expertise.
So, in the event you had a reluctant patient, a patient that was resistant to your advice, you would hang in there with him and try and convince him otherwise.
I would try to do my due diligence and understand their reason, his or her reason for refusing therapy or asking for another thing. But what I would do concurrently is to make sure that they got the right care, and I would ensure that I'm not partaking in what they're asking for if I feel that that was not in their best interest.
Now, for the 2 months that Dr. Murray did treat him with Propofol, you're aware of the fact that Michael Jackson was able to practice, was able to prepare for the tour, and basically there were no problems with the treatment during that period of time. Are you aware of that?
Objection. Assumes facts, not evidence. Calls for speculation.
The objection is sustained on compound.
Okay. He did treat him with Propofol for approximately 2 months, correct?
The records seem to indicate that.
And there's nothing that you reviewed to reflect that Mr. Jackson had any problems during that time, is there?
I'm not sure if I can answer that because I really don't have enough information as to his day-to-day state of mind and well-being.
Okay. But whether or not he had a problem, you feel that Dr. Murray's treatment in that manner was an extreme deviation from the standard of care.
Absolutely.
Because result and doesn't necessarily correspond with the type of care.
Objection, Dave.
Do you understand it?
I do understand that.
Overruled. You may answer it.
Right. In making a decision as to the degree of the violation of standard of care, the end result is not something that I would take into consideration, meaning ultimately Mr. Jackson's death. That is not that did not go into the decision of me saying that there was an extreme violation of the standard of care.
So in your mind, a doctor can practice what you would consider to be bad medicine, but things can work out okay in spite of that. Is that correct?
I'm not sure if I understand what you're really saying.
Based upon what you just described, and you're not concerned with the overall result, such as the death of a patient, the injury to a patient, a doctor can practice what you would consider to be bad medicine, but it wouldn't necessarily cause a bad result. Is that correct?
Well, I don't think that makes it right. I mean, the degree of deviation from standard of care, the end result is not important. There are instances where, physicians really are grossly negligent, meaning they have extreme departures from the standard of care, yet the end result may not end up really causing harm, resulting in death, for example, but they still are grossly negligent. And as physicians, as peer reviewers in the community, we have a responsibility to make sure that does not happen.
Okay. So when you're reviewing a case for the medical board, you're reviewing that without regard to the result actually obtained, aren't you?
I don't let that be a factor. I'm looking at actually the standard of care and the practice as it pertains to my area of specialty.
So you understand that in this particular case, the issues are a little bit different. Whether or not that gross deviation caused the death is the issue here. Are you aware of that?
I understand.
Okay. Now, based upon what you have seen, you've seen the coroner's report, also the toxicology report, Dr. Murray's statement. You know something about the condition of Michael Jackson. Can you tell us what happened on June 25th? The day that Michael Jackson died.
Well, I think to summarize, Mr. Jackson was receiving very inappropriate therapy in the home setting, receiving very potent sedatives, including Propofol, Midazolam, and Lorazepam, without appropriate monitoring, and by Dr. Murray, and ultimately this cocktail was a recipe for disaster in a patient that had underlying dehydration, and there was inappropriate access to the appropriate medical equipment, a delay in calling 911, and inappropriate resuscitation that ultimately culminated in his death.
Okay, now, you were talking about an inappropriate cocktail. Is that correct?
That's correct.
What was that?
Well, he had received, to begin with, oral dose of Valium, and thereafter he'd received on 4 separate occasions doses of both Midazolam, which is Versed, and Lorazepam, which is Ativan. And then this was followed by, I believe, around 10:40 to 10:50 a.m. by him receiving Propofol.
How much?
What is stated in the records by Dr. Murray is 25 milligrams intravenously.
Okay. Now, based upon what you have just related, would that cause Mr. Jackson's death?
Absolutely. Absolutely can.
Okay. Now, so you think the cause of death was 2 injections of lorazepam, 2 injections of midazolam, and a 25 milligram infusion of propofol?
I think it was really a combination effect of particularly Propofol, in addition mostly to the Ativan that he'd received in a patient who we had no baseline charting on. We didn't know what his status was. We didn't know if he was severely dehydrated. We didn't know if his blood pressure was low. We had no real basic vital signs on him. And I think this was the perfect storm that I described that ultimately culminated in his demise.
Now, when you say we didn't have this information, who's we?
Dr. Murray did not chart any type of records in terms of what, to begin with, what were his vital signs, what were basic heart rate, blood pressure, oxygen saturation, respiratory rate, basic physical exam before when he first came in and saw him, and certainly did not record anything thereafter. So there was no way of following any kind of a trend to see if there were any changes, any kind of effect from the medications that he was receiving.
And what you mean by there's no way for you to make those determinations, correct?
Well, the records do not show any indication of him having any charting.
Well, there are no records from that night, are there?
There are no records whatsoever.
That doesn't mean that Dr. Murray didn't obtain that information, does it?
Well, in medicine, just as it is essential. We don't store things in our minds. I mean, we cannot take care of patients if we just say, "Oh well, I knew this is what he told me or what she told me." We have to document things, and by documenting things, it's not just a tedious thing we have to do to keep records. It actually allows us to take better care of patients because it allows us to follow trends and remember, hey, this was, his blood pressure. When I first saw him, we take care of patients that have really bad high blood pressure. They come in and we do a procedure. Their baseline blood pressure may be 180, and then after we do something, it goes down to 120. That may be a normal blood pressure, but that to us, because of the charting, we are following a trend.
Overruled. It is. The answer remains.
Now, you prepare a record for every patient you see or do a procedure on, correct?
Absolutely.
And that's so that you will have it to remember and you can refer back to it. Is that correct?
That is not the only reason.
Okay, well, it's also so other people could refer to it and know what you did, correct?
That is one of the reasons. Right?
Now, as a result of Dr. Murray not having recorded everything he did at the precise time he did and all of the measurements that he may have taken that night and the monitoring information that he may have gotten from the pulse oximeter, and the fact that he didn't record it means that you can't interpret it. Is that correct?
Not necessarily, no. It actually means that he doesn't have the information. It's very easy to forget details. I mean, these are a lot of details, and it's important. We as clinicians, taking even care of that one patient that we're doing a procedure on, we still look at trends while we're doing it. We don't just rely on memory. So I would disagree with that. I would say that information is imperative not just for review later, but as we are taking care of patients.
So you have concluded that as a result of Dr. Murray not writing this stuff down as he went along, that he doesn't know it. Is that your conclusion?
Overruled.
I'm saying that there is no good way to really be able to follow patterns, and it can be a recipe for disaster.
Have you ever been constantly with the patient, basically over a 9-hour period of time?
Absolutely.
With just one patient?
I think I have, yes.
Okay, and when you're with that patient, what types of situations would that occur?
That would occur in the intensive care unit when you have really all it takes is one patient who's critically ill, who has multi-organ failure, who is gravely ill, requiring life support. That one patient can sometimes take up to 9 hours, sometimes even longer, and your presence as a clinician there throughout the procedure is vital. Even if the clinician, say it's me, is actively doing procedures to help resuscitate the patient, there's always a nurse that is documenting at every few minute intervals what is happening, what are the vital signs, and in addition to that, they're actually taking notes, what the patient looks like, what is happening at the bedside. So I have been in that situation.
And are you dictating those notes for the nurse to take down?
No, when the nurses chart, it's not being dictated by me. I do dictate notes, okay. But nurses do that spontaneously.
And are you doing that every 5 minutes?
In the intensive care unit?
Yes.
We have monitoring, and we have nursing staff that are recording that.
And are you recording your thoughts every 5 minutes about what you've observed?
I don't need to record. You mean on writing?
Yes.
I don't need to do that because I already have that record provided to me by the mechanism of having intensive care nurses.
And are you referring to it every 5 minutes?
I very often need to refer to it very frequently to really remind me of the trend. Sometimes when you're taking care of patients, you kind of are in the moment and you need to actually look at charting to really figure out what happened before to get a better picture because you are in the moment doing a certain procedure. So that's why it is imperative to have charting.
And so it's your opinion that as Dr. Murray is tending to Michael Jackson during that 9-hour period of time, there's no way he could have remembered what he did or what he observed unless he wrote it down when he did it.
I'm saying it is standard of care to write it down, and that it's an egregious violation of the standard of care when you are using sedatives like Propofol and not keeping any record and not charting very basic monitoring of the patient.
Okay, now, once again, we have another egregious violation, but that egregious violation, the fact that Dr. Murray did not write down that at 2 o'clock he gave 2 milligrams of lorazepam, that didn't kill Michael Jackson, did it?
I'm not just referring to the writing of of what he gave, but the writing of the vital signs. What was the heart rate at that time? What was his breathing pattern? What was his oxygen saturation? There's more to it than just the medication.
Okay, the fact that he didn't write that down at 2 o'clock. Whatever his observation may have been after he gave the 2 milligrams of lorazepam, the fact he didn't write down his vital signs, he didn't write down his blood pressure, he didn't write down his pulse rate, or what the pulse oximeter said with respect to oxygen saturation, that didn't kill Michael Jackson, did it?
Well, if you read my report, there's a number of things. This was just one of many violations. So it is really, again, a combination of many factors. You're just pointing to charting and saying, well, did the charting it was directly responsible?
I've got other things to go through,
sure.
too. But that the failure to chart was not a cause of death, was it?
The failure to chart was a contributing factor.
It's just an indication of what you consider bad medicine.
It clearly is bad medicine.
But it's not what killed Michael Jackson, is it?
I can't answer that based on...
Isn't...
Wait, allow the question. Allow the answer, please. Go ahead.
It's one of many factors. If you take that as an isolated event, just a physician that was just doing everything else right but was not charting, that would be very difficult to imagine. But it's really in the context of everything else that was done wrong.
Isn't what killed Michael Jackson the combination of a 2.6 level of Propofol combined with a .169 level of lorazepam?
Well, clearly, it was a combination of the propofol intoxication in addition to the lorazepam that he was on. That's correct.
It's the combination that killed him.
Right, but the circumstances, there were a number of circumstances that ultimately led to this. But yes, that was the direct cause.
What is it about that combination of drugs that you feel killed him?
Well, as I've discussed before, the additive effect of both Ativan, lorazepam, which is a sedative, in addition to propofol, can really have a profound effect, and that effect can be variable in different individuals. And again, that continuum between being just moderately sedated and going into a state of deeper sedation is very fragile and fine.
Okay, so that 2.6 level of propofol, when you add in that .169 lorazepam, the additive effect makes the propofol effect much more than it would have been at a 2.6 normally.
In terms of the blood levels, I'm going to defer discussion on blood levels because that is really more pharmacology and it's outside my realm. If you're just referring to blood levels alone, what I'm just would like to mention again is that combination can be a lethal combination when you mix those drugs in a patient that is completely unmonitored and not being watched attentively.
So am I correct in assuming then that a level of propofol characterized as 2.6, that's beyond your expertise to know the strength of that?
I would like to defer that to a pharmacology expert to discuss.
Is it beyond your expertise?
That is something that I would rather have discussed by a pharmacologist.
Do you have no knowledge of it?
Well, I do have an understanding of levels, but I would rather have that discussed by a pharmacologist.
Okay. And would your answer be the same for the .169 level of lorazepam?
Yes.
Do you have the expertise to determine whether or not that's a high level or a low level?
I would like to defer that to a discussion with the pharmacology experts.
Is that because you do not have the qualifications to answer that question?
No. It's that is an area that I would rather. I feel more comfortable not discussing and allowing for pharmacology expert to discuss.
Well, I don't know if your comfort level is really the issue that we're addressing here. I just wanted to know if you've made a conclusion in this case that the propofol plus the lorazepam that the lorazepam would accentuate the effect of the propofol. Would you also say the propofol accentuate the effect of lorazepam?
They work synergistically, that's correct.
Synergistically or additively?
Additively.
Okay, there's a difference between
Well,
them.
they can potentiate, one can potentiate the effect of the other.
Right. And it's an additive potentiation.
Correct.
But are you capable of determining whether, in looking at those levels, whether one level would be lethal without the other level? Do you know what I mean? Here. The level of propofol, would that be lethal without the level of lorazepam?
Again, I would like to defer on commenting on blood levels of those drugs and allow for the pharmacology expert to do that.
Okay. And so, along that line, would it be correct to assume that you have no idea how much propofol it would take to get to a 2.6?
a lot of it has to do with when the blood was drawn, and the level, the blood level may not necessarily be indicative of the level administered and the toxicity. And, and as a matter of fact, there are studies that have looked at people that have self-administered high doses that have died of that intoxication from propofol, and the levels were within a certain range.
What range?
Within a range of 1.3 to 6.
Okay.
So, again, I have an understanding and deep appreciation of the use of these drugs, but in terms of the pharmacokinetics and the pharmacology, I'd like to defer that to a pharmacology expert.
And the 0.16 level, 1.169 of level of lorazepam, would it be beyond your expertise to render an opinion as to how many milligrams that would take to be at that level?
Again, there's a lot of variables, and I think you're just giving me a very hypothetical question, and there's variables as far as timing. By just what you're saying, I don't think I can give an answer.
If you were to assume the facts that you've read about in the statement of Dr. Murray, that he gave a 2 milligram IV injection of lorazepam at 2 o'clock and a 2 milligram injection IV at 5 o'clock, would you have knowledge that would, or expertise that would enable you to determine whether or not that could give rise to the 0.169 level that was obtained in the femoral vein at time of autopsy?
Again, that is something that I would like to defer to a pharmacology expert.
Are you requesting to defer that to a pharmacology expert because you just simply don't have the expertise?
That is beyond the scope of my practice. And that's why I think I'd be better served answered by a pharmacology expert.
A pharmacologist might give a better answer, but are you saying that you are totally incapable of rendering an opinion in that regard?
Objection is indicated it's beyond his area of expertise, Your Honor.
Is that the bottom line?
That is.
Okay.
That's the answer to the question. Sustained.
Now, in preparing, you've also reviewed the records of Arnold Kline,
Yes.
and did you review specifically the treatment records for Arnold Kline for the months of April, May, and June of 2009?
I believe so.
And did you see, in reviewing those records, that Arnold Kline had given Mr. Jackson approximately 6,500 milligrams of Demerol during that period of time?
I do understand that he was treating Mr. Jackson with Demerol, yes.
And did you notice that every time he got Demerol, he was also getting Midazolam?
I did see instances of that as well.
Did you form an opinion as to whether or not Mr. Jackson had a Demerol problem as a result of review of those records?
Objection vague is the general problem.
You understand it?
I can't really answer that question based on purely the records that I have available from Dr. Kline.
Okay.
That's the answer. You may proceed.
You saw that when he got a Botox injection that the doctor gave him a cc or two of Midazolam?
Section,
Is
do
that
we have
correct?
a date reference?
Well, if you want a date record, I can.
It's not what I want. The objection is sustained.
Okay.
Rephrase the question, please.
Are you familiar with the drug Demerol?
Correct.
What's it used for?
It's used for pain control. It's a narcotic.
Are you familiar with the drug Midazolam?
Correct.
What's that?
That's a sedative.
Okay. Is Midazolam also used to alleviate pain on minor procedures?
It's used to make patients comfortable and sedate them for procedures so that they're not aware of the procedure happening.
And is 200 milligrams of Demerol a large dose?
It's a significant dose, yes.
And have you used it before?
At that dose, no. And as a matter of fact, I usually avoid using Demerol.
Why?
Well, my practice is mostly in the hospital with patients that are sick and have underlying significant medical problems, and Demerol the byproduct of it can have neuroexcitatory phenomena, and that's just not an ideal drug, particularly in patients that I really don't have, very good history, and really there are better alternatives to be used, and this is especially true in elderly individuals. So I don't, in my practice, I don't use it very often. I have in the past, but I don't.
You used the term neuroexcitatory. What does that mean?
It means that it can actually activate someone's, make them more hyper or excitable, make them more, create more of stimulation.
And when it metabolizes, does it form meperidine and normeperidine?
That's correct.
And is that the excitatory qualities that you're talking about?
That's correct.
The basic injection is kind of a hypnotic, isn't it?
Well, it can have hypnotic effects, but it's really a narcotic. It can have hypnotic effects, but it's really
Causes a feeling of euphoria.
it can.
And then after the euphoria leaves, it breaks down into the excitatory problem or qualities.
Not in everyone, but in some individuals that can happen.
And that can that cause insomnia?
That certainly can, yes.
And if that causes insomnia, that would be what you would term a secondary cause. Is that correct?
That could be a secondary cause. That's right.
In reviewing the records of Mr. Jackson that you've been able to review, did you form an opinion as to whether or not he had any problems with insomnia?
Yes, he clearly did. He
Clearly did.
Yeah.
And when you say clearly did you form an opinion as to whether it was, what type of insomnia it was?
Well, as I mentioned yesterday, there was really no time and effort or thought given to doing any kind of a workup to try to determine that.
Excuse me just a minute.
Objection, the witness is answering the question.
I was asking him if he made that
The
determination.
objection is overruled. You can ask your next question.
Did you make a determination?
It's very difficult as someone that's not taking care of a patient to make just a pure determination on something like that. It certainly seemed that there were issues that were potentially that may have resulted in secondary causes of insomnia. It's such as anxiety and perhaps a dependency to certain medications.
Is that a no answer? You did not make a determination?
It's what I mentioned is that there was no workup done to try to determine that, but by reviewing the records, there was clearly a suggestion that there were secondary issues. The answer is yes. There was some indication that there were secondary causes for the insomnia.
So you did make a determination as to the cause of his insomnia?
I'm saying that there were suggestions of it.
What's that?
Misstates the testimony.
Sustained. Partial answer stricken. Disregard.
I'm asking you a question. Did you make a determination as to what type of insomnia Michael Jackson had? That can be answered yes or no, and then give me an explanation.
Well, again, things are not always black and white, and in this scenario, there were suggestions from just reviewing the records. I was not seeing Mr. Jackson at that time or examining him, so I don't have all that information. But by just reviewing the records, there is again a suggestion that there may have been problems with him having anxiety for performing, as well as possible issues with use of drugs, medications such as Demerol.
So my question remains, did you make a determination as to what type of insomnia he had?
Again, I can't make that determination. I can maybe have a suggestion.
So your answer is no. You did not make a determination as to his cause of insomnia.
I think that there were strong potential for secondary causes. There's clearly evidence of that, and that's what I'm saying. But all I'm saying is that I can't exactly say what all those secondary causes were, because I didn't do the work. Okay.
Do you think that he had refractory insomnia?
No, I would not say that.
You mentioned in your report as one of your deviations from the you stated in your report, in fact, in referring to lorazepam and midazolam, they're not even considered as part of off-label armamentarium of medications for refractory insomnia. Why were you mentioning refractory insomnia in your report?
I was just trying to make a point that it is just so outside the realm of standard practice.
What is refractory insomnia?
One that does not respond to standard therapies. And like we discussed yesterday, standard therapies begin with behavioral and cognitive approaches and looking for secondary causes first and eliminating them, dealing with those underlying problems, and then getting into the medication management.
So when you eliminate the secondary causes, then you determine then it would be primary insomnia?
If the patient is still having symptoms, you've eliminated all secondary, you've done a very thorough workup as we've discussed, then that is the most likely case that it is primary. That's correct.
And once you determine that it's primary and the patient doesn't respond to your normal treatment that you would for primary, then you would determine that it was refractory. Is that correct?
Depends on what therapy. I mean, you have to give a patient a chance, and you have to go through the appropriate behavioral modifications that we talked about. You cannot just go directly to medical management and giving pharmaceutical agents to patients.
Am I correct in assuming that you've also read the records of Dr. Murray dating back to 2006, 2007, 2008?
In reference to?
Treatment of Michael Jackson.
There were some scattered minimal records that I did review, yes.
And you saw in those records where he had used other drugs such as Restoril?
I did see that, yes.
And you also probably saw from the reports there was other sleep medications present in the house of Michael Jackson, prescribed by other doctors.
I did see that.
And in the event that none of these, and so you did see that the insomnia dated back a long time, way before 2009. Is that correct?
There seemed to be a problem with that based. We're basing that not on any kind of record saying that this this insomnia has been worked up. What kind of insomnia it is, we're just inferring that by the fact that he was receiving medications that are traditionally used to treat insomnia.
Now, he had several doctors, to your knowledge, prescribe treatment for insomnia. Is that correct?
Yes.
Dr. Metzger, Dr. Kline,
That's correct.
Dr. Adams.
I don't recall.
Assumes facts not in evidence, and
I'm asking him a question.
I'll overrule the objection.
I don't recall that last
Okay.
name.
And would it be your testimony that if a person has sleeping problems and that those sleeping problems extend for a period of longer than, say, 4 weeks or a reasonable time such as that, that it would be beyond the standard of care to prescribe sleep medication without doing a sleepiness, I believe you call it a sleepiness test?
it's a testimony
Sleepiness scale? Epworth sleepiness scale?
I'm saying
Overruled. Did you use that term?
I did use that in one of many factors that I mentioned in the workup of a patient with insomnia, not just a sleepiness scale to assess the degree of the severity of the excessive daytime sleepiness, but also many other factors such as a sleep diary, such as looking for extraneous things, the environment that the patient is sleeping in, looking at other medications that they could be taking, nicotine, alcohol, caffeine. There are a lot of other things, but sleepiness scale is one of many factors that needed to be looked at.
Okay, so the first thing you'd start with would be the history.
That's correct.
Now, if you ever had a patient that you felt wasn't being forthright in their history,
I'm sorry?
have you ever had a patient that you felt was not being forthright in their history?
Yes.
How do you make that determination?
Well, I try to inquire as much as I can. I try to put every effort in trying to get as much information as possible. And I try to get information from other clinicians or hospitals that have taken care of the patient. So I try to not just always rely on the patient, but if they've been seen by other physicians, other hospitals, I make sure that I obtain all those records as well.
Okay, when you're obtaining those records, you have the patient sign a release,
That's correct.
and if they don't sign the release, you don't get that information, do you?
That's correct.
Because HIPAA doesn't allow you to do that.
That is
correct?
right.
And so if the patient, if you feel that the patient is not being forthright and is not willing to sign a release, what do you do?
Well, there are other parts of the workup that go beyond the history from the patient. Very often, especially in sleep-related disorders, one of the biggest things we rely on is the partner or anybody else that lives with the patient. We ask them, what is going on? Can you just tell us what's happening with the patient? What is their breathing pattern at night? What time do they go to sleep? What time do they wake up? What type of environment do they sleep in? So sometimes we actually have patients that really minimize, and that's very common in medicine, where patients just try to minimize and give little information. So if we have a spouse available who's there or a partner, we try to get as much information from them as well. In addition to that, we do things like the sleep diary we talked about, or the sleep log, where before we do anything else, we have them actually log their sleep pattern for a period of 1 to 2 weeks to see exactly what that sleep-wake cycle is like, when they're going to bed, when they're falling asleep, how many times they're waking up in the middle of the night. So that is imperative as well.
So if a patient reports to you having sleep problems, before you prescribed any medicine, you would get the sleep diary?
That's absolutely one of the...
You'd interview their partner?
Correct.
You would try to do background information, get background information from prior doctors?
If the patient consents, yes.
You wouldn't just give them a prescription of Ambien?
Routinely, no. No.
And would you be of the opinion that any doctor that prescribed, say, 30 Ambien without checking out all these factors that you've suggested here, that would be a deviation from the standard of care?
That is not part of my record. That it would probably not be a significant. People do that in practice. It's not right. I would say it's a very minor deviation of what is right. But certainly that's nothing I've stated in my record about someone using Ambien without having done a appropriate workup or screening.
So it would be okay to use Ambien without the workup?
Unfortunately, this is something that's done, and I don't think it necessarily falls outside the standard of care.
So if I told my doctor that I was having trouble sleeping and he gave me 30 pills of Ambien to take home or get at a drugstore, you'd think that's probably within the standard of care.
Well, again, your doctor is imperative on him to actually do an appropriate history and try to find out how long the insomnia has been, what are perpetuating factors, what is actually causing potentially the insomnia, what are secondary causes. I mean, the way you're describing it is really not the way it would be done. It would be only after a detailed history. And again, if there is a secondary cause that is apparent right off the bat, that process is dealt with.
And if that secondary cause was an addiction to narcotics, do you generally find that patients tell you about that?
Judgment relevance.
Sustained. It's a bit vague.
And you also indicate you do a physical examination. Is that correct?
That's correct.
So, and you said yesterday one of the things that can cause insomnia may be an enlarged prostate.
Well, I said that urinary problems that keep patients awake at night, that cause them to have frequency or have to go to the bathroom multiple times can be a factor.
So would you do a prostate exam too?
I wouldn't necessarily do a prostate exam on everybody, but here's the key. You ask about history. That's part of your history that you ask about, is to make sure that they don't have symptoms of prostatic enlargement, because it is, in the appropriate patient, very, very common. In an elderly individual, you want to ask about the urinary stream, you want to ask about frequency, the ability to initiate a stream of urine, but asking about doing prostate exam on everybody with insomnia, no, that's not a part of the routine exam on everybody.
Would you check their arms for needle marks?
Part of the physical exam is a complete inspection of the patient, and really with them putting on a gown, being able to examine their entire body. That is part of the physical exam. And if you do see something abnormal, whether it's a skin abnormality, whether it's a needle mark, a track mark, those are things that you have to document in your physical exam.
And if they were taking Demerol intramuscularly, would you be able to detect that?
That's variable. It can be, in some patients, it can cause potentially scarring. In some individuals, it can cause formation of tissue growth that's abnormal. It's variable. You may see it on some individuals and not in others. And it also depends on the chronicity and how much they've been using that and how much of that they've been receiving.
Now, you know that Michael Jackson was getting Demerol injections from time to time.
That's correct.
As many as sometimes 3 times a week.
I don't remember the exact frequency in terms of weekly.
Do you think that Dr. Murray should have been able to determine that?
Yes.
By a physical exam?
Not necessarily by a physical exam, but by a good history and by talking to the people that witnessed him being potentially having slurred speech or acting differently after he was receiving therapy at Dr. Kline's office. So I think that is very key, is to try to use whatever information you have and try to get as much information to try to treat your patient better.
Do you think from the physical exam he should have been able to tell that there was Demerol being used?
I didn't say that.
Okay. Oh, well, I
didn't say that.
I didn't ask if you said that. I just asked if you thought that.
Objection argument.
The objection's overruled. You may answer.
No, I didn't insinuate that the physical exam would be.
And if Mr. Jackson doesn't tell him about the Demerol that he's been getting on a regular basis, Dr. Murray should have interviewed other people at the house.
Well, people that were involved in his care that witnessed him basically acting differently, being more, having more slurred speech, basically people that witnessed a clear change in his sensorium, in his behavior after he had been treated there.
How do you know who those witnesses might be?
Well, there are people that are in very close contact with him. There are people that drive him there, that take him there.
So you feel it would have been incumbent upon Dr. Murray to interview security there at the house?
Well, it's you try to get as much information as possible to help your patient, and if it takes talking to his security, his personnel, his assistants, whatever it is, it's imperative to do that.
So would you consider his not having interviewed security a deviation from the standard of care?
Security in and of itself, I'm saying to...
Okay, his driver. Do you feel that not interviewing his driver would be a deviation from the standard of care?
What I'm saying is not interviewing people that were involved, that were witness to him having had any change in his behavior after that. Again, I don't exactly remember who those individuals were, but he was there, he knows, he would know, and those people need to be interviewed and asked about, and the patient needs to be confronted about that as well.
Now, if you have a patient that's not telling you this, you would then go out into, if he was brought there or accompanied there by his wife, you'd go out in the lobby, bring her in, and interrogate her. Is that what you'd do?
Objection misstates the testimony.
Sustained.
Would you do that?
Objection misstates the testimony.
We asked the question in its entirety, please.
In the event that you had a patient that you didn't think was being forthright, wasn't admitting to using these types of drugs that would affect sleep, would you, and he was accompanied there by someone else, would you go out into your lobby and bring that person in?
I would ask the patient if that was okay if I spoke with their loved ones or their spouse, and if that was okay with the patient, yes, that's absolutely what I would do.
And if it wasn't okay with the patient?
That's patient autonomy. I would not do that.
Okay. And if the patient was brought there by a professional driver who waited either in the street or in the parking lot, would you go out to the parking lot and interview that person?
If I heard from people, whoever it may have been, whether it was assistant, bodyguard, driver, that there were issues, that Mr. Jackson was acting differently, or that he was very drowsy, or that he had slurred speech, I would try to get as much information from those people and talk to the patient about it.
Has that ever occurred in your practice?
I've never been in that particular circumstance, no.
Okay. Now, do you know for a fact that Mr. Jackson did not have what you would call refractory insomnia?
Could you rephrase that? I'm sorry.
Do you know, have you formed an opinion and feel confident, as a matter of fact, that Mr. Jackson did not have refractory insomnia?
I did not have enough information to make a determination on whether he had refractory insomnia. There was just not enough of a workup that was done. And again, secondary causes were not fully worked up and ruled out and dealt with.
Now, I believe you said in your report that it's incomprehensible, unethical, and what's the other term? Beyond comprehension, beyond comprehension, disturbing and unethical to treat propofol or use propofol in the treatment of insomnia.
That's correct.
And I'm sure you are aware that there are studies involving that exact subject right now, aren't there?
There's very, 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 this is definitely not standard of care, and there is just some experiments at a very preliminary level that have looked at this, but certainly this is in no way a standard of care.
Well, in the study done by Dr. Zhu, it was stated that propofol is an efficacious and safe choice for restoring normal sleep in patients with refractory chronic primary insomnia. Dr. Zhu came up with that opinion, didn't he?
This is 2010 article council's referring
I
to?
think you need to frame the question so that it asks the witness if the witness is familiar with the article and may or may not have relied on it. Could you re-ask, please?
Sure. Are you familiar with the study entitled Propofol-Induced Sleep, Efficacy and Safety in Patients with Refractory Chronic Primary Insomnia?
The article, yes, from November 2010. Yes,
Right.
I am. Yes.
And in that article, they used propofol to treat insomnia?
They did. They used propofol in patients that had an extensive workup over a period of 6 months where they had secondary causes ruled out. If they had medical illnesses or psychiatric illnesses, they were excluded from being part of the study. The study was done in a highly monitored sleep center where there were anesthesia personnel or neurologists available. These patients had informed consent. They knew the risks and potential benefits of the therapy. And they were fasted for a period of 8 hours. And they were highly monitored. And they were receiving propofol via an infusion pump that was precisely dosed the amount of propofol that they were receiving.
And they studied 103 patients?
Correct. 64 were on propofol, yes.
And with respect to the patients that did receive propofol, 100% improved, didn't they?
Well, based on the endpoints they were looking at, there was better efficiency in sleep, meaning they fell asleep faster. They had less awakenings after sleep onset.
And in doing that study, they never had a problem with propofol with any patient, did they?
No, they did not have any significant complications because it was in a highly monitored center. These patients were using an infusion pump, and they were being constantly monitored.
But the net conclusion from the study is that propofol can be efficacious in the treatment of insomnia. Is that correct?
I think if you read the article, even the authors in the end explain that this is just a very preliminary experiment, and it needs way more further studies to ever imagine using this drug for this purpose. And again, this was in a highly monitored setting, not in a home.
I understand. It's a monitored setting. It's done by doctors, and there's been a tremendous workup of these patients. They've eliminated the patients down to being just the ones that had a severe sleep disorder, so severe that you would refer to it as refractory, correct?
Yes.
Now, with these severe sleep disorders, once they've identified their problem population, when they treated them with Propofol, in this study, they got good results, didn't they?
Based on this very prelim study, there were good results, but this was an experiment. It was an experiment. It was published in Cell Biochemistry and Biophysics. This is not a large randomized controlled trial that changes any practice of how we manage patients with insomnia. It just has no real clinical applicability.
Was that the conclusion of Dr. Zhu?
The conclusion, he himself mentioned that further studies are necessary.
Right. Now, do you think further studies should be done?
Overruled.
I think in the context of looking at the drug for inpatient management of sedation and the overlap properties with sleep, there certainly is enthusiasm at looking at Propofol and actually other agents that perhaps even share more physiological properties with sleep. But I think for the purposes of insomnia being managed anywhere outside of a highly monitored setting, no, I don't think there is any.
Okay, so if we do have a monitored setting, you then do think that Propofol might be efficacious in the treatment of insomnia?
There is not enough information for me to make that judgment at all.
But, doctor, you've made the judgment that you wrote in your report that it's incomprehensible that Propofol could be used for insomnia.
Absolutely.
But it's not incomprehensible by everybody, is it?
Again, the physicians in China were performing an experiment, and in a highly monitored setting. In standard practice, particularly in a home setting without appropriate monitoring, it is absolutely incomprehensible and unacceptable.
Okay, so you have to include for your determination of incomprehensibility a home setting, no monitors.
No, I'm just saying that that's additional factors that really culminate in this being just so egregious. But in and of itself, the use of Propofol for just inducing sleep, for treatment of insomnia is in and of itself incomprehensible.
And that would be like even in a hospital setting?
As of the current time, absolutely. We do not use Propofol for insomnia, even in the hospital. It is a far deviation from standard of care.
Well, when you use it in the ICU unit, and you use a Propofol drip, and you were talking yesterday about because people have sleep, because their circadian rhythm gets thrown off, because it's either daylight all the time or there's not a contrast. Well, you're using Propofol for sleep then, aren't you?
No. Propofol in that situation. First of all, let's not confuse. The issue I was discussing was delirium in the ICU, insomnia in the ICU, very often precipitated by what you mentioned, the change in the day-night cycle, the extraneous noises that patients hear, the beeping sounds, the people coming in and out and doing things to them, drawing blood, etc. Those are factors that result in insomnia. The treatment is not you giving them Propofol. We give Propofol in the ICU on patients that are on mechanical ventilation who have a breathing tube with a ventilator breathing for them. It's to make them comfortable so that the sensation of having a tube down the throat is not very pleasant. It's to sedate them and make them comfortable while they're on the ventilator.
When you say sedate them, is that also for purposes of enabling them to sleep?
I wouldn't look at it in the same way. I would say that it is for sedation.
Now, when you use Propofol for sedation, what doses are you talking about?
We usually start patients at a low dose, at about 5 micrograms per kg per minute, per kilogram per minute. And this is actually, patient's weight is dialed into these pumps, the infusion pumps, so they're very accurate. And the dose can be titrated upwards. Standard, most institutions, is to go up to about 50 micrograms per kilogram per minute, and to keep patients in that range, and making sure that they're not overly sedated, so that the nurses are always monitoring these patients, and if they become overly sedated, they're able to back off, and they're very aware of the physiological consequences of too much of the drug.
You use the Propofol to intubate the patient?
That's correct.
And what dose do you use?
The use of the Propofol and Intubate, it depends a lot on their underlying. If they are otherwise healthy individual who has no medical problems, less than age 55, around 1.5 to 2 milligrams per kg, we do a slow push.
A slow push?
Right.
Over what period of time?
Usually do it about 2 milligrams for every 10 seconds. So, usually over a couple of minutes.
Over a couple of minutes?
Yes?
Yes.
And then the maintenance dose, you do that by a drip?
That's correct. That's via an automatic drip where the patient's weight is programmed in there and the nurse is able to fine-tune exactly how much is being infused.
So you would put the patient to sleep with approximately 1.5 to 2 milligrams per kilo.
A healthy patient who, like I said yesterday, has blood pressure is stable, there's no other issues, that is a standard dose. Every patient is different, and if I have a patient that is hemodynamically unstable, their blood pressure is low to begin with, I don't even go to Propofol as an induction agent. I may choose another agent because I'm aware, and even though I'm in a very controlled environment in an intensive care unit, I still choose another agent. So you have to treat every patient individually, and again, it depends on the patient. If that same patient who's stable, otherwise his blood pressure is stable, is elderly, above age 55, or has chronic medical conditions, I would tend to use a lower dose, something like 1 to at most 1.5 milligrams per kilogram. So every patient is different, and you have to pay particular attention to the underlying comorbidities, underlying issues that they have.
Have you ever used a lower dose than that to put a patient to sleep?
Yes.
How low? What is your experience? What's the lowest dose you've ever used?
I've used 50 milligrams of Propofol in patients, actually rather routinely, for induction.
So the dosage used by Dr. Murray of 25 milligrams infused over about 3 to 5 minutes is a very low dose, isn't it?
That is a low dose, yes.
And that's not a dose that you would expect to cause complications, would you?
Not necessarily, because when you have a patient that to begin with may have poor reserve, meaning they have underlying issues, they have dehydration, their blood pressure may be low, and you add to that the factors such as the sedatives that they had received, such as the lorazepam, then I think all bets are off. Then you really can't be still 100% sure that that is not enough to kind of tip them along that sedation continuum and cause a deeper level of sedation and compromise their ability to breathe.
But if you have an otherwise healthy patient and you have no reason to believe that there's an active dose of another drug, that 25 milligrams, you wouldn't expect to create any problems over 3 to 5 minutes, would you?
Can you be more specific about the type of patient? And I mean, there's a lot of factors. I think it's kind of a very open statement. I would have to know a lot of details when I'm making a decision to induce a patient with a deep sedative.
You had a patient that weighed approximately 61.7 kilograms.
Mm-hmm.
And you had no reason to believe that they had any significant health defects. And you had no reason to believe they had any kind of therapeutic dose of any other drugs in their system. You wouldn't expect 25 milligrams over 3 to 5 minutes to cause a problem, would you?
Objection. Irrelevant hypothetical, improper hypothetical.
The objection is sustained.
On irrelevance?
Improper reliance on facts, not in evidence.
You've been critical of the use of lorazepam for insomnia. Is that correct?
That's correct, particularly in the intravenous form. Yes.
The PDR describes lorazepam as useful for insomnia, doesn't it?
The PDR does, but it's not one of the FDA-approved medications for use of primary insomnia. And that's what I was alluding to.
But if a physician looks in the PDR and he looks up lorazepam, it's going to say that it's useful for treating insomnia, isn't it?
Lorazepam in the oral form can be used, although it's not FDA approved. It can be used in insomnia, particularly if it's secondary to some underlying anxiety disorder. Yes, it can be used in that setting in the oral form.
Now, when we talk about oral versus IV, if a physician is there administering lorazepam via IV, he can control how it's received into the patient, can he?
Objection made.
Do you understand it?
Not really, no.
Sustained. Yes, please.
You draw a distinction between the oral form and the IV form. Could you explain why
Well,
there's a significant difference to you?
right. Well, in a management of insomnia in the outpatient setting and even in the inpatient setting, there is, again, Ativan or lorazepam has really no role. some patients that have underlying anxiety for a very short-term basis, it can be used, although it's not FDA approved. And the reason for that is there is great dependency. After patients use it for any prolonged period of time, after a few weeks, they can actually become dependent on it. In what I mentioned is that to use an oral form for a short-term period to treat insomnia secondary to anxiety is appropriate, but to use intravenous form is really not. I mean, that's just really inappropriate.
Isn't the main distinction between IV versus oral is the percentage of the drug that you actually get into the patient?
That's correct, and monitoring has a big deal to do with that. So it's really imperative to be monitoring these patients. I mean, we use Ativan in the ICU as well, in the intensive care unit, but these patients are on continuous monitoring. Their blood pressure, heart rate, saturations are being continuously monitored. So it's I'm not sure in what setting you're referring to.
I wasn't referring to any particular setting. I was just referring to the difference between IV and oral.
Well, what I was saying that to use it in the intravenous form, you need monitoring, and it still is not a recommended therapy, FDA recommended therapy for insomnia.
Is it beyond the standard of care for a doctor to assume that the information in the PDR is accurate?
No.
I mean, if the PDR says that the lorazepam can be used for insomnia, should a doctor not rely on that?
Well, a doctor needs to do their due diligence and treat every patient individually and appropriately. I don't think the circumstance you're describing really depicts how we take care of patients. We just don't open a PDR and say, hey, this drug can be used for insomnia. Let me give it, and let me give it in an IV form. Really, every patient has to be treated individually, and everything we described has to take into account. And using Ativan for that in that setting can really only be justified on a very short-term basis for treatment of transient insomnia associated with some underlying anxiety disorder, for example.
When you say short time, what are you talking about?
Less than a few weeks.
Okay. In the event that the anxiety is caused by, a pending event, is such as practicing to go on a world tour and going on a world tour, you can appreciate that it caused some anxiety.
Clearly.
It could also probably increase a person's tendency towards insomnia.
It can.
And the lorazepam might be used to relieve some of that anxiety?
It can, but the correct choice in that situation is to have an expert. To know what your limitations are is to have an expert, a psychiatrist, evaluate that patient and determine what is the best treatment. Using Ativan in that situation is just is really having a fire that's out of control and just sprinkling some water over it without really gaining control of the underlying problem. Is really to deal with the underlying anxiety disorder from both the behavioral perspective and also from a pharmacological perspective. Medications, antidepressants that have particular role in treating anxiety and very often which is associated with depression and insomnia. So that would be the route.
So what you're saying is you would not have used lorazepam in this particular situation to treat this anxiety?
No.
It's a double negative. It's a little tricky. Would you?
Would
you?
You would not use lorazepam to treat anxiety.
Is that a correct statement?
No, that's not the correct statement.
Oh, it isn't. All right.
You wouldn't use lorazepam to treat a temporary anxiety.
I would consider it in an oral form in addition to treating the underlying problem, addressing the underlying anxiety disorder with appropriate psychiatric and psychological help and medications that really address the problem. These are really mostly the class of antidepressants and not using lorazepam.
And if the anxiety was caused by a pending job, it's going to take you about 9 months to complete. Your solution would be to say, get rid of the job.
No, that's actually more reason, if it's 9 months, that you do not. We just mentioned that if you do even consider using the oral form of Ativan for anxiety, it would be for a very short period. So if you have this everlasting, lingering anxiety taking you up to this event that is 9 months away, you want to deal with the underlying problem. I'm not suggesting that you cancel the event that is leading to the anxiety. I'm saying you need to address the underlying problem appropriately.
Let me know when we can take the mid-morning break, Mr.
Right now, it'd be fine.
All right, thank you. Ladies and gentlemen, let's do that. We're going to take the mid-morning break. Please remember all of the admonishments, the written and the verbal admonishments. There'll be a 15-minute break. Thank you.